start this presentation, we're going to talk about what is pelvic pain. We're going to go over pelvic floor functions in the anatomy. We're going to discuss different types of pelvic pain, the role of physical therapy in treating pelvic pain, and then different PT interventions and resources that you guys can access. So the goals of this lecture is to recognize the different types of pelvic pain that may affect those with female anatomy. This presentation is not geared towards those with male anatomy. We are going to understand the role of physical therapy in treatment of pelvic pain. We will differentiate between the different types of pelvic pain, and you should be able to identify providers and resources to contact for support. So we just have a little disclaimer. The information provided in this community education lecture is for educational purposes only. We are not here to diagnose you with a specific pelvic pain diagnosis or provide you with specific treatment techniques. If you suspect you have pelvic pain, please seek medical guidance from your provider and then ask for a pelvic floor physical therapy referral if indicated. We do not have any financial ties to any products or resources that might be presented here today. All right, so let's get started. All right, so in this first infographic, we have the cycle of sexual pain. So just because somebody has pelvic pain doesn't necessarily mean that they will have pain with sex, but this is a good example to kind of show you about how people experience pain and the cycle that kind of goes on. So first, the body experiences or anticipates pain. This might not only be a physical reaction to a painful stimuli, as fear and anxiety can contribute and make you think that something is going to be painful before it even happens. Second, then the body automatically tightens the muscles of the vagina. 3, then tightness will make sexual intercourse painful. Penetration may be impossible if these muscles tighten up enough or if the pain is severe enough. 4th, that pain you felt then reinforces or intensifies your body's response to tighten up. And then 5th, the body reacts by bracing or tightening up surrounding muscles on an ongoing basis. And essentially your body is just constantly on defense mode. 6th, because things are painful and because muscles are tight, we see that people will avoid being intimate and they may lose interest in sex. This then feeds into that first step where our fear and anxiety then further perpetuates the cycle of pain. Okay, so now we're going to talk about what exactly is pelvic pain. So chronic pelvic pain is defined as pain in the abdomen or pelvis that lasts more than 3 months and is not caused by diseases or conditions such as endometriosis, dysmenorrhea, or dyspareunia. So dysmenorrhea is painful periods. Dyspareunia is painful intercourse, and endometriosis is when you have endometrial-like tissue that's growing outside of the uterus. So those are their own thing. They don't count as chronic pelvic pain. So with this chronic pelvic pain, pain may be felt in the lower abdomen, vulva, vagina, perineum, anus, or the tailbone. So chronic pelvic pain affects 1 in 7 women. One study showed that the prevalence of pelvic pain was 39% in women of reproductive age in primary care practices. And of all referrals to gynecologists, 10% are for pelvic pain. So this is common enough. So I'm going to be lifting off a bunch of different conditions that may potentially be causing pelvic pain. So we have low back pain, nerve entrapment, depression, constipation, irritable bowel syndrome, peripartum pelvic syndrome, uterine ruptured fibroids, ectopic pregnancy. We have malignancies or cancers of the bladder, the colon, or the uterus, endometriosis, pelvic congestion syndrome, pelvic inflammatory disease, radiation cystitis, interstitial cystitis. When you see that word cystitis, that refers to the bladder. Infections, abdominal or pelvic floor trigger points, hydroceles, varicoceles, polycystic ovarian syndrome, adenomyosis, pelvic inflammatory bowel disease after a surgical procedure, such as like an ultrasound, a biopsy. Hip labral tears can create some pain in the pelvis, or having even back issues, like such as a lumbar fusion. We also have yeast infections, swelling of lymph nodes, herpes zoster or shingles, atrophic vaginitis, sexually transmitted infections, hemorrhoids, and genitourinary syndrome of menopause. So there's a lot of different conditions that could cause pelvic pain. So on this slide, it just kind of gives us a good idea that when providers are diagnosing pelvic pain, they have to consider all these different body systems. So it lists off like gynecologic, gastrointestinal, urinary, musculoskeletal, neurologic, vulvar, vaginal, psychiatric. And so there's a lot of different systems to consider to truly find out what's going on and get an accurate diagnosis for why you're having pain. So now we're going to talk about conditions that are commonly treated by us. So we have coccyx pain or tailbone pain, groin pain, anismus, so that's more like your butt pain, levator ani syndrome, that's also a type of pain in the butt, sacroiliac pain, so that's like in the back of like your hip joints, genital pain, pudendal neuralgia, post hernia repair, pelvic congestion syndrome. We have painful bladder syndrome or interstitial cystitis, chronic pelvic pain, vulvodynia, pain with penetration, also known as dyspareunia, perineal pain, proctalgia, Fugax, did I say that right? Okay. Pain with pregnancy. So lots of different things that we can help with. This is a nice quote that I think kind of goes along with what we're talking about. So time is not a cure for chronic pain, but it can be crucial for improvement. It takes time to change, to recover, and to make progress. So just because you've had pain for a long time doesn't mean that it can't get better. And you do have to give yourself some grace and give yourself time to see those changes, because you didn't get that pain in one day and it's not going to go away in one day. So next we're going to talk a little bit about anatomy. So here we have the pelvis, which you can see in the picture on the left. It's made up of 3 bones that are fused together. This bony cage helps to hold and protect the uterus, bladder, and rectum. The pelvis also serves as an attachment site for various muscles in our back and legs, as well as the pelvic floor muscles. There are 3 different layers of pelvic floor muscles, which not only help to provide support to the organs above it, but to also assist in bladder, bowel, and sexual functions. We're going to go into more depth about each of these layers in a little bit. So we also have ligaments that not only attach to the bony pelvis, but it also helps to hold some of the organs, such as our uterus, in place. And then lastly, in our abdomen and in our pelvis, we have fascia that coats the organs, muscles, ligaments, nerves, and blood vessels that are housed in this bony pelvis. So then in the picture on the right, you can start to get an appreciation for all these different structures that are in this area. So this picture on the right is a cross section, and we can see the bladder in the front, and then behind that, the uterus, and then behind that, the rectum. And then behind that, you can see several of the nerves branching off the sacrum or the sacral plexus. And you can see that pink band of tissue in the back and the thin pink line behind the organs. And those are the pelvic floor muscles. So when we think about all the different structures packed into this small area, it makes a lot of sense how you can have an issue with one organ or structure or muscle, and that can result in different symptoms such as pain, constipation, difficulty with urination, or you might have multiple different things going on, and the symptoms may overlap, making it difficult to distinguish what is the exact root cause of your pain or dysfunction. All right, so we're going to be working our way from deepest to more superficial, or more like closer to the surface. So we're going to start by talking about our pelvic floor muscles, and this is the deepest layer. So this is the third layer of the pelvic floor, and it's also known as the pelvic diaphragm. And in this group, we have a group of muscles called the levator ani, and that includes the puborectalis, pubococcygeus, iliococcygeus, pubovaginalis, and puboanalis muscles. We also have the coccygeus muscles, as well as a couple hip muscles such as the piriformis and obturatus internus. Those muscles help with like rotation of the hip, and those guys neighbor the pelvic floor and can sometimes refer pain back and forth to one another. And then here, we just have another picture of those layer 3 muscles. It just gives you a different view. And you can see how those muscles attach onto that bony pelvis, and it basically creates this hammock to support the organs above it. So then we go on to the layer 2 muscles, which are also known as the urogenital diaphragm. These muscles lay just a little bit deeper than the layer 1 muscles. This layer includes the deep transverse perineum, so it connects from one sit bone to the other. And it's also underneath the sister muscle, the superficial transverse perineum, which we will mention in a minute. Then we also have the urethral sphincter, compressor urethra, the sphincter urethral vaginalis, which wrap around the urethra and they help with peeing. And we also have this perineal membrane, which is the layer of tissue that serves as an attachment point for the muscles and organs above it. This here shows the layer 1 muscles, otherwise referred to as the urogenital triangle. This layer is made up of bulbospongiosis around the opening of the vagina, the ischiocavernosus running along the bone at the top, and the superficial transverse perineum muscles running across the middle and connecting to our sit bones. And lastly, we have the external anal sphincter surrounding the opening of the anus. So here we have a great image that helps to clarify the difference between the vagina and the vulva. In general, we hear people refer to lady parts as the vagina, but it doesn't matter which structure it is. You either hear people talking about the vagina or the clitoris, and then they seem to forget about the rest of female anatomy. So just to clarify, the external genitalia is the vulva, which is a term we are finally hearing a little bit more of, and is what most people are referring to when they are talking about the vagina. So the vulva includes the labia majora and minora, otherwise known as the lips. It includes part of the clitoris, the opening of the vagina, and the opening of the urethra. On the other hand, the vagina is internal and it's a deeper structure, as it is the part that connects the vaginal opening to the cervix. So here is another more anatomically correct picture of the vulva, and there's a few structures that we just want to highlight. So most people are familiar with the anus and the vagina or vaginal opening. And then we have the perineum, which is the space between the two. Then we have the labia majora and labia minora. So those are our outer and inner lips, which are closed on the left picture, and then they're open on the right. Then we have the clitoris at the top, which is partially covered by the clitoral hood. Most of us are familiar with this structure since it's most commonly associated with the orgasm. Then less commonly talked about, we have the vestibule, which is the space between the labia minora. It includes the Bartholin glands, the skein ducts, and the opening of the vagina and the urethra. And this structure is outlined by Hart's line. This is an important structure to make note of because later we're going to be discussing vestibulodynia, so we want you to know what area we're talking about. So now we're just going to talk a little bit about pelvic floor functions. And so since we've talked about the anatomy already, it's going to make a lot more sense what the pelvic floor actually does for us. The pelvic floor has 5 distinct functions, also known as the 5 S's. So the first is sphincter control. The pelvic floor controls when we pee, poop, or pass gas so that we can go when we want to go and we can hold it in when it's not time to go. Secondly, it helps with support. So the pelvic floor muscles support our rectum, our bladder, our uterus, and our abdominal organs against gravity. Third, it helps with stabilization. So it helps to form our core and give stability to our back and pelvis so we can do our everyday activities. Fourth, it helps with sexual appreciation. So these muscles of our pelvic floor can assist in pleasure and orgasm, but when they're dysfunctional, they can result in pain. And then fifthly, it is a sump pump. So it helps in circulating fluid and blood back up towards the heart. So now Alyssa is gonna take over and talk about the different types of pelvic pain.
Thanks, Monica. All right, so the first type of pelvic pain that we're going to talk about is dyspareunia. We commonly see a ton of patients for this diagnosis, but it's not in itself a diagnosis. It's more of a symptom, and it is very common in the short term for postpartum women at about 3 months. We define it as painful vaginal penetration in the absence of disease, as Monica mentioned earlier, and it can be associated with several other conditions, but also can be caused by insufficient lubrication, changes in hormones such as postpartum or perimenopause, injury, trauma, or irritation, surgeries or medical treatments, emotional factors such as a history of abuse, stress, or other psychological factors. Chronic pelvic pain. So the American College of Obstetricians and Gynecology define chronic pelvic pain as continuous or non-cyclical pelvic pain of longer than 6 months duration that localizes to the anatomic pelvis, abdominal wall, at or below the umbilicus or the belly button, the lumbosacral back or the buttocks, and is sufficient severity to cause functional disability or lead to medical care. So about 25% of people with female anatomy may spend about 2 to 3 days a month in bed, which may limit their activities greater than 50%, 1 to 3 days a month. Many of them, 90%, so the majority of them, have pain with intercourse, and nearly 50% of these patients with chronic pelvic pain feel sad or depressed. Another common, pain during pregnancy can be posterior pelvic girdle pain, sacroiliac joint pain, or lumbopelvic pain, as Monica explained in the anatomy section, symphysis pubis dysfunction, anterior pelvic girdle pain, could be round ligament pain or position of the baby, rib dysfunction, or dyspareunia. So we're going to go into each of those. So one of the most common types of pain that can occur in the pelvis is posterior pelvic girdle pain. So in the back part of the pelvis. If you remember back to the first anatomy slide that Monica presented on, the bony pelvis includes the hip bones, so the ilium and the ischium, and then we have the pubic bones. These bones are in the back. They're connected via ligaments to the sacrum and can make up the majority of the pelvic pain. People that present with posterior pelvic girdle pain will likely need a lot of manual therapy, which Lorraine will discuss, to reduce pain, support systems to help stabilize and control pain, and then proper exercises to help stretch, mobilize, and stabilize the area to reduce pain. In one study, there was 86% of pregnant people that experienced pain in their 3rd trimester, and many will also have pain beyond that 12-week postpartum timeframe if not treated. Symphysis pubis dysfunction. So the pubic bones are connected by cartilage known as the pubic symphysis, and a sudden increase in the hormone relaxin can cause a shift and increase pain. And some of these symptoms can include burning, popping, clicking, and a deep ache. In most cases, the pubic symphysis is related to pain that will be reduced post-birth. However, if this continues to be a problem, then we really recommend coming back to pelvic floor PT or coming to pelvic floor PT for treatment. So you can see in the picture that red area right in the middle of the pelvis is where a lot of patients will have their pain. Approximately 1 in 300 pregnancies experience pubic symphysis pain. And from my experience with treating patients with this diagnosis, many of them are told by their providers that this is just normal and it will go away, but it can be very debilitating for them. So now we're gonna shift to ligament pain. So round ligament pain, you can see in the picture here, that's going from the uterus down to the front of the pelvis. Then we have our broad ligament here, and then we have our uterosacral ligament that is connecting the back part of the uterus to the sacrum. And then we also treat a lot of patients with hip pain or groin pain. So this picture I thought was really nice to kind of show all the different areas that we typically see patients who have some kind of hip or groin pain when they come in and see us. And many of these patients have gone to see other therapists in the past and have not gotten to, where their pain is managed on a normal basis and they need a little bit more help. So our job is to help you identify your pain and teach you movement strategies to reduce it. We also love to use kinesiotape in order to help combat that pain, which will allow you to move better than sometimes having to wear a belly band or a belt. Rib dysfunction. A lot of people don't think that the ribs can be a part of your pelvic pain, but in pregnancy, the rib cage expands and shifts tremendously. So therefore, there can be changes based on the baby position, work-related postural changes in sleeping positions that can refer pain. Pelvic floor PT can help with reducing tension in certain areas with visceral and myofascial treatment techniques. Then we're going to go into vulvovaginal pain, talking about vaginismus, vulvodynia, and vestibulodynia. So we're going to start off with vaginismus. So it's an involuntary pelvic floor contraction or spasm that prevents the ability to have vaginal penetration. And that can be with a multitude of things. That could be using a tampon. That could be going to the gynecologist or midwife for your annual exam. That could be with a toy or with penetrative intercourse with a penis. I loved this picture on the pain cycle that talks about what's going on with our body's response to pain. So it starts in the brain. And when you experience pain with vaginal penetration, this internal alarm goes off. It's the amygdala alarm, triggering your body's natural fight or flight response. And even though you may not be in a life-threatening situation, it can feel like you are. At that point, your amygdala can take over and make it very difficult for your prefrontal cortex in your brain to think rationally about the situation and remind you to stay calm. Then that you're stuck in that fight or flight response, you start to muscle guard. And the pelvic floor muscles, particularly the ones in the layer 1 that Monica described, they start to tense up and they guard against the threat of vaginal penetration. Sometimes with vaginismus, this fight or flight response can remain activated and the muscle tension can become chronic. From there, we develop the vulvovaginal pain. So attempts to penetrate anything into the vagina through tight overactive muscles can lead to even more pain. We then go into a negative reinforcement. So if you're experiencing this pain cycle over and over again, your body is going to guard against it. That experience will fuel future fear and anxiety. So it's going to kind of like bounce back up to that amygdala response and that emotional pain. Then phase 5, we have imprinting. As the pain cycle continues, your body is unable to forget or ignore the negative experience, and the potential for pain is marked or imprinted on this part of your nervous system. It's like your foot being stuck on a gas pedal. You can either end up stuck in survival mode at this point. Then we go into avoidance. Our pain, if you have pain, it doesn't feel good, and neither is worrying about it. So instead of staying in the mood, you end up avoiding sexual activity and or dreading sex altogether, further strengthening the fear and anxiety associated with vaginal penetration. This will push you back into the pain cycle, giving your amygdala the confidence it needs to continue hijacking your body's response. So there's the superficial pain that can occur with vaginismus, and then there's also the deep pain. So some of the things that may cause that deeper pain with vaginismus is endometriosis, pelvic congestion, interstitial cystitis or painful bladder syndrome, levator ani syndrome, or uterine retroversion. So vulvodynia. So vulvodynia is vulvar discomfort, most often described as burning pain, occurring in the absence of relevant findings or a specific clinically identifiable neurological disorder. And that's a definition from the International Society for the Study of Vulvovaginal Disease. Some symptoms that can occur with vulvodynia is burning pain in the vulvar area, stinging, rawness, irritation or an irritating feeling, allodynia, which is pain in the absence of where pain should not occur, and then hyperalgesia, so having a lot of hypersensitivity to that area. For a diagnosis, the provider must rule out other potential causes. So we're thinking of any other vulvar dermatological causes, any yeast infections, UTIs, bacterial vaginosis, contact dermatitis, general herpes, HPV, atrophic vaginitis, cancer, nerve or muscle-related pain, or any neurological disease. And questions predicative of a diagnosis is that somebody experiences genital pain and genital burning greater than 3 months, as well as 10 plus episodes of tampon insertion, intercourse, or a gynecological exam, and pain on contact that limits intercourse. A cotton swab test can be very reliable in determining if the patient has vulvodynia. And that is something that both OBGYN, midwives, any other providers that are doing any type of vulvar and vaginal assessments can do, where we would touch around the vulva to identify areas of localized pain. A lot of the times we're also going to talk to you about what you're wearing. If you're wearing lots of tight clothes all the time and you're having these irritations, does that go away if you're not wearing those things? What about, during your period, or you're trying to use tampons, or have you really avoided that altogether and you're using pads? How often are you changing them? Have you shifted your usage to more of the period underwear, where there could be some increased chemicals in those products that, we really would rather you not use, and go more towards an organic product? And vestibulodynia. So it's a subtype of vulvodynia characterized by pain to touch at the vestibule, which is the area around the vaginal opening between the labia minora, so the inner lips. So in this picture, it's this inside darker area here that we're looking at, versus if we're looking at just vulvodynia, we're going to be separating the labia and we're going to be just a little bit outside. So it's more of like a few millimeters of a difference when we're looking at, vulvodynia or vestibulodynia. We also can do a cotton swab test in this area to differentiate where the pain is. Pelvic congestion syndrome. It's often thought to be more prevalent in a person who has struggled with varicose veins prior to or during pregnancy, and you are at a higher risk of getting pelvic congestion syndrome with multiple births. So with a diagnosis, your condition is thought to be due to enlarged veins in the pelvic area. And you can see them here, where these veins are very congested. They're not allowing any of the blood flow to come through, whereas the normal vein on, I think it's the left side, is much smaller. A CAT scan or an MRI can help get a better picture of the abdomen and the pelvis to get a better diagnosis. And sometimes providers will also start with an ultrasound of the ovaries to see this. And some of the treatment that can occur with this is hormone treatment to reduce the ovary function and surgery. And the surgery would be done by an interventional radiologist to help reduce that the congested veins around the ovary. And levator ani syndrome. So this is often characterized by literally a pain in the butt. It is a spasm of the muscles of the third layer of the pelvic floor, causing pain in the rectal or perineal area. Many of our patients will say that they have a sharp pain in the butt, or they feel like they may be sitting on a ball. We get a lot of patients say, I feel like I have a marble or a golf ball that is constantly in my pelvis. Or if I get a spasm, I'll feel like I just have like a knife that's being like shoved in my butt. And it's never a pleasant experience. In order to help treat this, we want to reduce the tension with stretches and mobility, manual therapy. We may need to do some internal treatment, which Lorraine will go over, possible need for some diet changes to improve your bowel habits. And we want to help improve your functional activities. And so if you're somebody that has levator ani syndrome and you have a sitting job or you have to drive a lot for work, that's really going to impede your ability to do those things. And coccydynia or tailbone pain, it's most characterized by painful sitting, especially when moving from sitting to standing, and with defecation or having a bowel movement. It's 5 times more likely to occur in women than men, and the onset of age is around 40 years. But it's not to say that this does not happen in somebody who's younger. If somebody has had multiple falls from a direct injury, this could cause a fracture or a subluxation. So somebody who has fallen on their butt a lot. Recently had a patient from one of our orthopedic therapists who was learning how to snowboard and fell on his butt like greater than 10 times in one weekend and developed coccydynia. We also have hypermobility that may cause this, disc degeneration, tumors, osteomyelitis, or abnormal mobility caused by factors such as obesity, prolonged sitting, bicycling, rowing, or riding. And now Lorraine is going to go through the role of pelvic floor therapy.
Thanks, Alyssa. So what is pelvic floor physical therapy? Well, physical therapists, we work to promote, maintain, and restore health through physical examination, diagnosis, management, prognosis, patient education, physical interventions, rehab, disease prevention, and health promotion. So pelvic floor physical therapy, it's a specialty within physical therapy that focuses on the pelvic floor, the abdomen, hip, and low back musculature. It's a very, precise and special area of physical therapy, and it's not necessarily given during our schooling for our degrees. It's an extra. What we commonly treat individuals as, Monica and Alyssa talked about, is bowel and bladder, incontinence. We address constipation, urinary urgency, frequency, pelvic or abdominal pain, pain with sexual activity, prolapse, pain during pregnancy and postpartum, and abdominal muscle separation. So as physical therapists, we have a general treatment progression that we like to follow. And when it comes to treating those with pelvic pain, we really want to address the pain first. Our initial goals may be decreasing muscle tightness, down training your nervous system to get you out of that pain response, And this may include breathing or relaxation strategies. And ultimately, we want to get you to some more of those functional goals, which might include allowing you to be able to use a tampon or a menstrual cup without pain, having a pain-free internal gynecologic exam with the use of the speculum or the fingers by your provider, and to allow for penetrative intercourse without pain or discomfort. So our pelvic evaluation starts off like any physical therapy eval. We first take a look at, the order that your doctor's sending us and looking at your history and any medical, and surgical history that's also sent, from the physician or provider. We want to get an idea what's going on. We're going to review your symptoms. We're going to ask about bladder and bowel and pelvic habits and ask any other questions that we might think relevant. And a lot of the first visit, we want to know your story. You'd be surprised. You might think that, oh, they don't need to know that. And you tell us something, maybe you had, years in the past, you fell on your bottom, during gymnastics or something when you were, a kid and landed on your coccyx. Oh, but it's all healed. That might be important to us. All right. So don't think anything, is not out there for us to know. We're going to do what we call like our first orthopedic screening. So we're going to screen your back, your hip, the abdominal pelvic, region for pathology. We're going to assess your strength, the range of motion of your hips, your back, your lower extremities. We want to feel what's going on in the abdomen. Is there pain in the abdomen? What's the fascia going on? We want to see how you breathe. All right. We love diaphragmatic breathing, and that is some of the strategies we use with treatment. After a sense of how you're moving as a whole, we like to perform our external examination first. And we're going to ask your permission. And we're going to ask if you want a chaperone with you. Okay. Externally, you saw those great diagrams that Monica and Melissa had about, the vulva, the vaginal opening, the anal opening. We're going to look at the perineal body. All right. Think about, that area in between, the vagina and the anus that goes across. Those of us that have had babies, that's what can get injured and torn when we talk about, tearing and episiotomies. So we want to feel externally, is there anything painful? What does your skin look like? Do you have hemorrhoids going on? Then with your permission, we're going to ask to do an internal assessment. And again, if you want a chaperone or not, what the internal does is this is where we're going to go in those layers that Monica talked about. And now I'm going from the most superficial layers to the deeper layers. So we have a gloved, our hands are gloved. We use lots of lubrication. We'll go in with one of our, fingers. You're going to let us know if something is painful. All right. If you want us to stop, you're in charge. We're not going to continue, all right, without your comfort and permission in mind. So the first layer, we're about at, our nail bed. We're not that far in. And that's where we can feel, the SPT or STP, we call it, the ischiocavernosus and the bulbar cavernosus. See what's going on. If there's pain, we may ask you to, hey, do you know how to do a pelvic floor muscle contraction or not? Next, we're going to go a little bit deeper, probably like to our first knuckle, and that's where the second layer lies. All right, so we're feeling for the compressor urethra. All right, we're very gentle, okay, because urethra and bladder are close by, and we're kind of slinging around. Think of like the bladder or the clitoris at 12 o'clock, all right? The pubic bone, the perineal body, that's at 6 o'clock. So we're going to sling around the urethra and the bladder on either side and feel where those muscles are, if there's any pain there. And again, we might ask you to contract. What's going on there? Can you engage those muscles properly? Next layer, the third layer, all those great muscles in there. We're feeling for pain, trigger points, spasm. We're going to the back, like if you're the down below, headed towards like the back end of your vagina and feeling towards the rectum through the vaginal wall is where we're feeling where these muscles are. Remember, the urethra, the vagina and the rectum are like tubes that are going through those muscles. So they encompass those canals. So if something's painful and spasm, who better take care of that than physical therapists? That's our big role, is helping with musculoskeletal problems. We're not there to do a gynecological exam. Okay, we're not trying to feel for your cervix, feel for the uterus, all right? But depending on how long our palpating digit is in your canal, we might be in that area. It's okay, that's within our realm. We're, again, looking for pain. You're going to tell us what is going on and what we're, there to help. All right, so we finished our internal with the palpation, and then we're going to look to see what's the strength of those pelvic floor muscles. If we can even get that far, depending like why you're coming to us, but that's another thing, is we test the strength of the muscles internally. So we're feeling for, is there any type of a contraction? If there's like just a flick, or if there's like, wow, I can feel all the way around our digit, those muscles encompass. Are you pulling us in and upwards? All right, that tells us something. And then we're going to see how long you can hold that contraction for. All right, we talk about that as the endurance. And then the muscle has a fast component to it. All right, so, if you're coughing or sneezing, you got to be able to like quickly, those muscles engage so that, the urethra is tightened around so we don't lose any urine, okay? So we're going to see how quickly you can relax the muscle and then engage the muscle and then let it go. And that tells us something. We also can feel for prolapse, all right? So if we're feeling different pressures that you may not know about on the back end, of the vagina, on the front end of the vagina, or straight down, that tells us something. And again, once we get all that information, we're going to share that with you. And then we're going to help determine the goals of what is going on. Okay. And as you can see, from here with the pelvic exam, okay, there we go. We're talking about our tissue quality, the contraction and coordination, and again, where areas may be. Okay, so this kind of just shows what goes on internally. Okay, so you can see where we are. Okay, I look at the third layer, it's almost like, to me, I call it like the wine glass. The canal, we start going up layer 1 and 2, and then 3 opens up, and that's where you can get into the hip area, these deep hip muscles too, that people didn't even realize, like this could be causing some of their low back pain. It could be coming from these deep hip muscles that you really can't get, externally. The best way to get them is internally. So this is what you look like on the inside, okay? Okay. Now, we can, evaluate vaginally, okay? But we may also need to look at or feel the pelvic floor if there's, a rectal problem going, anorectally, or even, there could be something going on vaginally, but, you might not tolerate this. So this is just a little picture showing, how the anatomy lies. So you can see, the digit is through the anal opening. So either side lying or on your stomach, okay, depending on comfort. Yes, we've also have patients, they can be on their back as well. We're going to work around you for your comfort, but this helps us just, get at some of these deeper pelvic floor muscles. And we're checking for, the levator ani syndrome, the coccydynia, constipation, anismus. In this position, going through the anus, you can really get up there and feel along the coccyx. I've had people that have had a dislocated coccyx, and you're able to do a joint mobilization through, this area. Okay, now we've done our eval. We've told you what's going on. So what are we going to do as physical therapists to help you? All right, so it's physical therapy. So traditional, good old manual therapy, that includes joint mobilizations. Okay, talked about the coccyx, all right? Trigger point releases, all right? If those pelvic floor muscles are screaming and spasming, we can do trigger point releases. We do soft tissue work through the vaginal, wall. We do strain, counter strain. We feel for trigger points. Your anterior iliacus, that's a deep hip, muscle, the iliopsoas, trigger points. Quadratus lumborum, trigger points. The piriformis, we can be working on those. How they all affect what's causing some of your pelvic pain. We're going to check, we've looked at the myofascia. We do myofascia release. We do visceral mobilization. That's actually working along the organs. If they're bound down, we have releases that we work on. We can work on muscle energy. So if your sacrum or that pubic rami is not a happy camper and muscles are affecting it, we call muscle energy. A little bit different than what chiropractors, they manipulate. We mobilize and use this muscle energy technique. We do dilator training, using that for vaginismus and dyspareunia. Dilators are a device that simulate, kind of like a vibrator that we might use for some pleasure, but they vary in their size. And it's a specific way of stretching the pelvic floor muscles and the vaginal canal to allow for, penetration of the vagina. We're going to work on your scar. Maybe you had a C-section and we got to work on that, afterwards. We've had, work post-hysterectomy that be causing some pain. There could be scarring, an injury from when you gave birthing through the canal that we can address as well. So lots of things, again, in the realm of physical therapy. It's our same treatment modalities that we do if you're coming to see us for your neck or your back. We may use thermal agents. So if there's pain along that perineal or along the vulva, we may be able to do ultrasound. That's the treatment ultrasound, not the ultrasound that we get when we're pregnant or for diagnostic. We may use heat and cold as well to help with your pain. We do functional training. So working on activity of daily living positions. How can we get you out of positions that cause pain or get you into positions that you couldn't do any prior because of the pain? We got to restore those. We can also use some agents of electrotherapy. All right. You might have heard of TENS. That's what we call transcutaneous electrical nerve stimulation. That works on some of our pain theories through the brain. We might use high volt pulse current, electrical stim, and interferential, stimulation. And these are, again, some things that we can use to help with your pain. Exercise, stretching and strengthening of the floor, the girdle, and the trunk muscles around there, and some aerobic. We may use biofeedback. So biofeedback is a device that you can use to, either hear someone's really, really tense in their muscles. We have like an electrode probe. And oh man, when you're hearing it, it can be off the wall. So it's like, all right, we want you to quiet those muscles. So sometimes being able to hear, that noise, it's like, and then using some of our strategies with relaxation, you're able to basically, we call like kind of down train, relax those muscles, okay, which is a nice thing. Also, if somebody's weak though, and they can't seem to get a contraction, okay, now we want that noise. So the biofeedback can be used as a way to show you, hey, look at, you're able to kick your pelvic floor in. All right. And then we talk relaxation. So especially with pelvic pain, the relaxation part of it's really, really important. And I know it's hard when someone says, oh, relax, yeah, right, it hurts. How am I supposed to do that? So we talk about through use of imagery, autogenic relaxation, and muscle discrimination. So, guided imagery, it really can work. Getting people into either there's different apps that you can use. There's different things we do in the treatment room with you to help you get through your imagery along with your breathing. But what's autogenic relaxation? Well, that is what we call, it's a training. It's a relaxation technique that uses the power of the mind to relax the body. So the term autogenic means coming from within. So you can also think of it of a form, they say, of like self-hypnosis. So you would establish, a routine practice which may improve your overall health. And then muscle discrimination is learning to control the response of your muscles. So this is how we help you, gain some of that control back of, that muscle relaxation. Okay, hello. Uh-oh, Alyssa, am I stuck? Nope, okay. All righty. So here's some, oops, did I go too far? Okay, here we go. Sorry about that. resources. So there's help out there besides pelvic floor, physical therapy. All right. If you're having issues with vulvar pain, there's the Vulvar Pain Society, National Vulvodynia Society, Pelvic Pain Society, International Pelvic Pain Society, and the International Society for the Study of Vulvovaginal Disease. There are a lot of really good care people out there that are really doing research on these problems. All right. So yes, as women, we were told, we don't know, kind of deal with it. Or have you been told it's in your head? Well, guess what? It's not. All right. There is help out there for you. And then these are just some additional resources for books out there as well that are a great, source. So one, Why Sex Hurts, Pelvic Pain Explained, The Playbook for Painless Sex, Heal Endo, and The Headache and the Pelvis. And these are some references. Right. Yeah, and you're going to have access to this as well, so no worries, okay? But there's, like I said, a lot of research going into this field. Okay. And so we want to thank you. Just so you know, when you come to, pelvic exam with us, Monica and Alyssa and myself, okay, you want to have a doctor's order. All right, you want to make sure that you've seen the doctor and get cleared and bring that referral. You can give our office. This is just how you reach us, okay? So there's our number and the option 2, all right? That gets you directly to the department. Our fax is there as well. So, if you've seen your doctor and they've given you your script, you give us a call.